Thank you very much for the opportunity to pitch today. Aaron Donnelly is my name. I'm an ophthalmology SPR at the Royal Victoria Eye and Ear Hospital. My project is entitled Crosslinking Thin Corneas, the Sub 400 Protocol. I'm presenting on behalf of the cornea team, which also includes Diana Malata, our specialist nurse in crosslinking and ophthalmology, and Mr. Barry Power, consultant ophthalmic surgeon specialising in corneal surgery. So keratoconus is a condition which causes progressive thinning and biomechanical weakness of the cornea. In advanced cases, it can lead to corneal scarring, and some patients even require corneal transplantation to improve their vision. A corneal transplant is a very invasive surgery, has a number of risks associated with it, and requires lifetime monitoring. So the aim really is to prevent the disease from progressing to that stage. Crosslinking is a highly effective treatment at stabilizing the cornea and prevents the disease from progressing in the majority of patients. It's an office-based procedure, generally performed in a minor operation room, where the corneal epithelium is debrided, cornea is then soaked in riboflavin drops, and then finally the cornea is irradiated with UV light. And those steps together lead to an increased stiffness of the cornea, increased covalent bonds between the collagen molecules, which ultimately strengthens the cornea and prevents the keratoconus from progressing. And since crosslinking has been introduced approximately 20 years ago, the rates of corneal transplant needed for keratoconus has reduced dramatically worldwide. So it is a very effective treatment, but unfortunately, historically, it's only been offered to patients with corneas thicker than 400 microns. So patients with thinner corneas, 200 microns, 300 microns, have simply been observed, and in some cases they progress and then require corneal transplants. The reason for this is that it was shown that the standard cross-linking protocol delivered a toxic level of energy or UV energy to the corneal endothelium, and that corneas thinner than 400 were at risk of corneal endothelial failure after cross-linking. But more recently, a few years ago, a group from Switzerland, the ELSA Institute, published a paper in the American Journal of Ophthalmology looking at a new technique for cross-linking these thinner corneas. So the steps are very similar to the ones I outlined before. The corneal epithelium is removed. The cornea then is soaked in riboflavin for 20 minutes in order to try and swell or increase the thickness of the cornea. The main difference is that a pachymeter is then used after this stage to measure the thickness of the cornea. And then based on a nomogram that the group published, the irradiation time or the UV time is then determined based on the thickness of the cornea measured with the pachymeter during the procedure. And they had very good outcomes. They showed that 90% of patients did not progress and there was no evidence of endothelial failure. So we're seeking funding of €4,114 and 35 cents to purchase a handheld pachymeter for a cross-linking theatre. All the other materials used during the procedure are the same, so the same UV light is used and the same riboflavin. We feel that there'll be multiple benefits, first of all to patients, so that those with thin corneas can now be included, and as a result there may be lower corneal transplant rates and lower hospital attendances. To the health service itself, corneal transplant surgery is expensive and requires frequent hospital visits, which of course are an added cost to the health service. And then finally to the tissue bank, which manage the corneal tissue. So it's known that corneal tissue is in short supply worldwide, and these tissues should really be reserved for non-keratoconus corneal disease. Thank you very much.